and thank you for joining us today. My name is Teresa Powerski, and I'm the Area Director for Business Development at Civitas Senior Living. And I have the pleasure of being in the company with Dr. Agarwal, and he is with Alpha Healthcare Medical Associates. Thank you for joining us today.
Thank you so much, Teresa.
November is Home Health and Hospice Month, and we are talking to different providers and physicians regarding community education to help spread awareness. In the spirit of that, we are talking through different questions and topics to help provide different education and information surrounding each one of the topics. So thank you for joining us today.
Thank you, Tricia. It's a pleasure being here.
Thank you. So to start off, can you tell us a little bit about your background and what drove your interest into primary care and home health?
Absolutely. Tricia, so my name is Anshul Agarwal, and I've been practicing primary care family medicine for close to 15 years now. What I like about primary care and how I got drawn to it, during our medical school rotations, you rotate through different departments like surgery, primary care, different specialties. I was drawn to primary care because primary care kind of take the ownership of the patient as a whole. And, they know in and out of the patient just like a family member would know you. So that was the appeal to me, and not just one focused thing. We focus on each and every system, but kind of take the ownership of the patient, kind of a gatekeeper of the health of the patient. And also preventative care. Primary care does so much of preventative care, where actually the job of a primary care doctor is to keep you healthy, to keep you from falling sick and going to the hospital.
Right.
And that's where the home visit part and the home health part is also very integrated to primary care. So those are the things which drew me, and also the lot of gratitude. The more you know a patient, the more you explain them the diseases, the gratitude is just amazing. I think no other specialty matches that as like the primary care. So that's what drew me.
Can you tell me a little bit about the difference between home health and home health visits?
Sure. So at Alpha Health, we are a full array of comprehensive, primary care services where we have multiple locations. You can come and visit us where face-to-face a doctor and, can see you and do tests if needed and explain you stuff. But what happens, especially in seniors, a lot of patients with a lot of complex conditions, we have noticed that they are not able to go to the doctor that often. And what causes that? Causes their medical conditions to get worse, and maybe a little bit because they're not able to get the care by going to the doctor frequently. What we can do is, or what home visit is, where a licensed board certified provider, a doctor or nurse practitioner, can actually go to your home with their kit, with their electronic medical record system, with their examination setup, where they can be in your house. So your house becomes a medical setup, a medical facility, where they're able to examine you, they're able to send whatever chronic medications you need or change your medications, reconcile everything what has happened, maybe during the last visit with the hospital, and even coordinate between your specialists to make new referrals. So that's what a home visit is. And home health is when the home visit doctor, a licensed provider, will engage under their company, like in this case, Choice Care, where a nursing aide can come more frequently to your house to give you skilled nursing, like maybe check your sugar or, check your blood pressure, or if there's wound care needed. There's so many things going on. So home visit is actually a doctor or a licensed provider seeing you with the medical decision-making capacity. And when they decide, okay, this person or this patient needs more chronic care on an ongoing daily basis, that is when home health is involved. So home visit is the doctor and home health is the nursing part. That's the difference.
Okay, that's helpful. And then we could also have orders written to if they needed therapy in the home, like physical therapy or occupational therapy or speech therapy.
Exactly.
That could be also added benefit into the home. It sounds like we have opportunities there that telemedicine is also available with visits.
Right.
Can you tell us a little bit more about that?
Absolutely. So, like I explained, home visit is when the doctor or the provider can go to your home. It's really needed the very first time to establish care, so the doctor or the provider can, examine you, by feeling your organs, by, listening to you. But once that care has been established, we can do home visits, on a regular interval to kind of manage the care. But a lot of times, if a particular patient who has more medical problems or more complex, problems, they can actually, see us on a video conference call the provider, where the provider can see the patient, talk to them face to face, and kind of visually examine them, but do the same care by prescribing medications or sending referrals to specialists or any new orders which need to be added. Now, during last 2 years, COVID, this telemedicine, where a video conference, between the patient and the doctor has become a very integral in healthcare. A lot of doctors have gotten used to it. A lot of patients have gotten used to it. The platform we use at Alpha Health is a very user-friendly platform.
Okay.
Especially with seniors, when somebody, who's a 75, 80-year-old, my parents, they are technically, they have problems downloading an app, and I can only imagine how it is with seniors. So our telemedicine platform is very simple. You don't need to download a platform.
Okay.
Just a text message will come to you. The doctor or the provider will guide you how to use it.
Great.
As soon as you click on the link, it opens up the video and you can actually see. As long as you have a smartphone, that's all that is needed. And you can use your family member's smartphone for that. And that's how, the telemedicine visit can be done. And we can take care of you at the comfort of your house, and we can examine you. There are certain cases where patients, they had, say, maybe a leg swelling, and on the phone, they were able to reverse the phone and show me the leg or the ulcer, that how it looks now. And then that's very, I think, groundbreaking without the patient leaving the house or, keep waiting for an appointment. It becomes very convenient for the patient to do that.
Yeah, that is convenient. I'm sure they're also able to get quick access to their test results and have that available to them.
Exactly. That saves a lot of the driving time for the patient or for the provider to the house. But typically for follow-ups, I think telemedicine is really integral, where the doctor already knows the patient or the provider knows the patient. They have seen the patient in person. And once they have established the care, the follow-ups can be done on a telemedicine platform.
That's great. That's wonderful. It's a great service to have. With November being Home Health Month, what comes to mind when you think of awareness surrounding home health?
Sure. So when home visits or home health comes to mind, I want, especially the seniors, a lot of patients were there, in their house. I don't want you all to feel stuck. You should not feel that, okay, I cannot go to the doctor. I cannot, have what the care you need, you cannot get access to that care, and you have to just go to the ER or the hospital. That is not the right thing, because once you go to the hospital, hospitals are needed, but sometimes it can complicate things. With November being the home health month, our goal is to keep you healthy, prevent all those hospital visits, and we can do that by coming to you to your house, in person, or also by telemedicine. So I think it's really vital to, maintain your health using the home health and home visit. And I think November we can dedicate that month to that. So I think more awareness needs to be there, where patients know that this facility is available and they have access to care. Even every day if you want. As long as we can see you and find out what's going on. So
that's great. That's wonderful. So with your patients and especially just kind of from the family experience, can you tell me about some of the benefits that you've seen with your patients and your families who've been on service?
Absolutely. So one of the biggest things we notice, especially in complex, patients, suppose a 85-year or 90-year-old patient, they have multiple things going on. And, it's tough being in that situation, especially when you're not able to go to the doctor. And what ends up happening is the people or the family members taking care of that patient, they get anxious, they get worried.
Right.
And I would worry too if I had my parents in such situation. So the only access they have is to the ER. So they end up taking the patient to the ER. The ER doctors or the hospital doctors don't know the in and out.
Right.
So they will try to understand your disease, what's going on. They might end up doing a lot of tests and keep you in the hospital. Which sometimes a lot of this can be prevented if there's one provider who's seeing you at home at the comfort of your house. They get to know you, your medical problems, and they can prevent all this from happening. So I think this is something which is very vital in home visits, where a doctor or physician can come, and home health, where companies like Choice Care can involve to continue that care at home. So a lot of, again, awareness is needed. ER and hospital is not the only choice you have. So engage with some providers like us who can come to your home and give you care at home, at the comfort of your home, and prevent all these, admissions or worsening of your medical condition. conditions.
Right. And that brings up a good question. So if you are a patient that's on home health services and you start to feel ill, so trying to avoid having to go to the emergency department, what do you suggest for your patients if they're starting to feel ill or sick?
Oh, absolutely. So that's a great question. We have a actually 24/7 access line where you can actually, before going to the hospital, you can call us and maybe we can do a telemedicine to assess you.
Okay.
And we can tell you, okay, you know what? This does not need to be seen. We can send a medication right away electronically to your pharmacy if some of your family members can, or maybe we can give instructions on the phone, or if something which needs to be taken care of, in an urgent matter, we can come the very next day or same day to your house to see you. So that's what they need to know. Now, some conditions, if they need attention at the hospital, we can guide you on the phone or telemedicine to, that, okay, you don't really need, then you should go to the hospital.
Okay.
So that's where the home health and the telemedicine can come into, really helpful for the patient and the family members.
That's great. That's great. Yeah, and having that good communication with your care providers and a nice relief to be able to have for the family members that they have that support of the care team and have that resource available.
Absolutely.
So that's great to hear. When you have one of your patients who are on home health services, how do you suggest is the best way that they can help support their loved one at home? Any suggestions that you have, any conversations that you have with them that they can help best support them, especially if they have maybe young families
Sure.
at home or they're working a full-time job?
Sure. That's a great question, actually. So I'm very thankful a lot of times on seniors, who have complex medical conditions, and I see some of their family members are there with them. That is so important to be with them, especially when they're having this, either the home visit or if the patient is coming to the doctor to understand what's going on. I think education is power, empowering the family members and the patients with the medical condition. What should be the next steps, what needs to be done, what does the do's and don'ts for every medical condition, the red flags versus when to take to ER, when to call us. So I believe the family members, the more educated they are in their loved one's health, the better the outcomes are.
Okay.
Because then they have more confidence on what's going on with their loved one. And even if the patient maybe is very complex or they're not in a position to take care of themselves, the involvement of family member and understanding what's going on is so important to
Right.
take it to the next steps and get them better. So that's why I think involving the family member, we can help educate, we can help explain the next steps, do's and don'ts, and our services where they can feel free to contact us if they have any questions.
That's helpful.
So that's why involvement of family members is very, very important.
That's great. Yeah, and especially because there's enough community resources that are available. So if they needed to bring in additional aides into the home,
Absolutely.
and just being able to help share those different resources.
Absolutely.
And so I guess that kind of brings up the next question that we have is, so if you have a family member that they're starting to feel overwhelmed and you're kind of looking and seeing different cues, when do you kind of notice that there's additional opportunities to have conversations with family members, that there are opportunities that there may be opportunities to have conversations regarding living in a senior living community?
No, absolutely. So I can't even emphasize how valuable senior living communities are. One of the things we've noticed is, the family members, they try their best. They are emotionally bound to their loved ones. They want to do the best, but practically sometimes it's not possible because you're doing it out of the love for your loved ones. You want to take care, but they have a job, they have their family to take care of, and sometimes it's out of your scope of practice where you can take care of that patient, as just a member. So if the patient is so complex, our dementia patients are the most, I would say, common, which fall into the category where you need to be in a senior living facility.
Right.
The advantages of senior living facility, hey, you don't have to be stuck alone in a situation.
Right.
In a senior living facility, there are a lot of social and a lot of behavioral aspects to that, because you're in a place where you'll find a lot of other members who are in the same boat as you, or you'll find a lot of other, senior or assisted living facilities who are the same age group, and they have a lot of activities they can do together.
Right.
So it feels much better than being stuck at home and getting, your medical conditions worsen or complicated. They're better equipped, they have senior living facilities, they have a better environment, and not just from a physical health, but also from a mental health perspective. I think it's important to involve them at the right time.
Absolutely. Especially the different options of independent living, assisted living, or if they were needing memory care to be in a safe environment. So,
Exactly. It takes a whole village to take care of such complex patients, and the family member has to be an important part of the village. The doctors have to be part of the team member, but no one can do it alone. It has to be teamwork, everybody being involved together and understanding that one patient.
yeah, absolutely.
And I want to, everyone to know that home visits where a provider can go to your home health, for example, choice care, they do a good job where nursing aid is coming and seeing you. That does not limit you not to come to the doctor. This is an extension of our care. You are still welcome to come to the doctor's office as needed, or some things which can be only done in the doctor's office, like, say, example, if you need a joint injection, if you need, a biopsy or some, other injectable medications. So always remember, it's not just home visit, home health. You're always welcome to come to the doctor's office. As long as we know you, we have established care, we can provide this whole array of services in the clinic, outside the clinic, at your home, referrals, orders, whatever is needed, we'll take care of your complex medications. Our goal is to keep you healthy. Our goal is to help you understand, your family members to understand what's going on, and that trust, to develop that trust so that you don't feel alone or stuck in a situation. So one of the things which a licensed provider can do when they're visiting at home, certain things we notice, that, okay, this needs actually a specialist referral, or this needs a specialty, care. And we can provide that when we're at home, because our electronic systems are capable of generating the referrals to a specialist, and we will get you to that specialist when the care is needed. So I think that's very vital, because sometimes, the only choice you have is go to the hospital where you can see the specialist, but by that time you're waiting when the medical condition is already worse, and then you're getting to see the specialist in the ER, through the ER to the hospitalization. But we can prevent all of that by preventing this happening by seeing you in home or telemedicine, and we can refer you to the needed specialist much before the condition gets worse.
Perfect. Yeah, that's really helpful. And really making sure that everyone's on the same page, has the same communication. So that's helpful. I have the pleasure to be at the company with Dr. Mark Mazzare, for the Medical Director of Choice Home Health and Hospice. He is also with Vigilant Healthcare Solutions. Thank you for joining us today.
Thank you. It's a pleasure to be here.
Great. So I wanted to just start things off by talking a little bit about your background and your interest for joining into the field of hospice.
Well, thank you. It's kind of a long story, but my interest in hospice really began from when I was back as a hospitalist. One of my earlier jobs was to work in the hospital, taking care of hospital patients. And I obviously was around a lot of patients that were toward the end of their lives, and I began to see the need for someone to come alongside and help during that really difficult time of not only the patients' lives, but the lives of the families that are dealing with that. And as I moved into doing more assisted living and nursing home work, and as I began my practice, I just was more aware of the needs of the families as we would try to explore all the different areas of the end of life, especially when we could no longer offer additional treatments. And as I began to be involved in hospice, I began to learn from hospice as much as a learning for me. As I learned, I was able to help and teach the patients and families. And so it was an educational process for me, because coming from as a physician, we are always trained to give the right medicines and expect patients to get better. And that's sort of what we're always used to doing. And when we get to the point when there is no more treatments or the patient's no longer responding, it's tempting to think, okay, well, my job's done, or even to think I've failed because there's nothing else that is reasonable to do or that we can offer. But what I discovered is that through so many doctors that were hospice physicians and watching them, even watching some that were going through terminal illnesses themselves, I was able to see how the real comfort that physicians can give and nurses and other hospice personnel becomes more relational, and it becomes more of a to give pain relief, yes, but so much more is developing that relationship and then demystifying a lot of the challenges of end-of-life care, of saying what to expect, letting people understand what can be done, how we can help preserve dignity, how we can help families work through their differences, how there can be reconciliation, healing in different families. And we see all those things take place because we're there and we can give our experiences to the families and to the patients, and we can share with them, what that journey is about. And there's so much healing in just knowing what to expect and knowing that someone's going to be walking with you on that journey that's been there before, and we have that therapeutic relationship. And that's something unique that physicians and nurses can have with patients. And that was something that before I worked with hospice, I didn't know what kind of benefit that my presence and my participation could be, because I thought, well, my job's done. But it turns out that it can be a very healing and therapeutic process beyond the medical. And that's one thing I appreciate, and one thing I've really grown to love about hospice is that connection that I have with patients, and it's one of the most rewarding parts of my practice.
That's so nice to hear. So at your practice, I hear that you're doing a lot of amazing work surrounding telemedicine. Did you want to tell us a little bit more about that?
Yes. I really appreciate what telemedicine can bring. Obviously, COVID has brought telemedicine front and center in the healthcare world and in our everyday lives. We're so much more we're well versed in telemedicine now because of the communications we've had to have because of COVID and the isolations. But even before COVID, I saw how technology was really transforming medicine. And we, in the teaching hospitals and the training hospitals that I was a part of, we would do remote consultations to rural areas and things, and there was robotic surgeries being done and all of those things happening remotely. And it just made sense that the communication was such that there could be so much information and the two-way communication could happen, and expertise could be available to so many more people. All they had to have is some kind of a technological link, and that became, and that's become so prevalent now. So I've always seen the benefits or the potential benefits of technology, and from an expense standpoint, you can have doctors reach out to so many more people in in a short amount of time, and stay in touch so much better. So I just always thought that this should be used more. And then of course with COVID, then it just accelerated that time frame, probably about 10 or 20 years. When you look at the pace of medicine and how quickly we latch on to new things in terms of practice changes, it probably would have taken us probably 10 or 15 years to get to where we are now. And I think that's just a good thing, because we're seeing so many people that were unable to get out or avail themselves of the healthcare system, or they live too far out into the community, or they live in a place that doesn't have good medical coverage. Just by being able to be reached through the telemedicine, it really gives those people a way to get healthier and stay healthier. And so I'm really, really happy to pursue that in my practice. So we've what we try to do is basically do a tradition as much and as close to a traditional practice as we can, even including x-rays, labs, immunizations, all the things that you would get in the doctor's office, and also being able to monitor patients for their blood pressure and blood sugars and get in real time that transmitted to our staff that can deal with them. And then also being able to stay in communication with the patients through the technology, whether it's email or phone or by the video, so that we're not just seeing patients, once a year or so, but we're staying in almost constant contact until those problems get resolved. And that way, we are able to be a part of really seeing patients change their health, because so many of the health problems that we see are lifestyle changes. We have to make changes, and helping them make those changes in addition to getting their medicines it really is kind of a complete picture. And so we're able to really see a lot of real changes and advancements in the patient's care and health, where maybe traditionally they hadn't experienced that.
Right.
So it's not only is it as good as traditional care, but in some aspects it's better.
Right.
I'm not going to say it's going to replace the visit to the doctor face to face. There's usually times when that's the only way we can get information, but there's so much that can be done through telemedicine that, and some people have just absolutely no other recourse because they can't get out or they have other limitations, that we're really seeing it. We see it as a way to reach those people and to really provide care in that way.
Right. And what a great opportunity to have that convenience and access to care. Can you tell me a little bit about how the family can be involved with having telemedicine available?
Yes. Well, obviously, very few people are just by themselves with the technology, especially as we get older, and the older populations, they may not be as familiar, although they're getting very familiar now with the technology. But so many times families are, they're not just in one location. We'll have families, that are basically all across the country, even across the world.
Right.
And, with a smartphone, many times they can just synchronize in with the visit itself.
Great.
And even participate. So that is one way that's just impossible even in person to do for most families. They can't all be there. But now with the technology, they can all come in at the same time with a meeting, video meeting, and participate.
Great.
And then also, even specialists. So you can have multiple doctors talk about the same patient at the same time in real time. So there's lots of things that technology allows us to do that we really couldn't do with traditional medicine.
Right. Very comprehensive. That's great to hear. What are some of the things that come to your mind when you think about community education and awareness?
Well, I think when it comes to hospice, it is very important to have a month like Awareness Month for hospice. I think it's something that we see being involved in hospice. We see a lot that people are hesitant to become a part, or either they don't know what hospice is, or there's a lot of fears surrounding the end of life, and a sense of giving up, perhaps, or a sense of I want to try all the things that we can first before hospice. And I think there's some kind of a disconnect where almost it's like there's no treatment with hospice. And that's actually it's like the opposite is true. You actually get more access to healthcare personnel. You get nurses, and you get a lot more visits. You get a doctor that is focused on your care, and even curative care. When patients get acutely ill and they're on hospice, they may have a terminal diagnosis, but they get a cold or they get other problems, they get treated because those are things that are contributing to their they're feeling poorly and what we call morbidity or things that make them feel bad. And we treat those things so that they can feel better quicker. Now, those same patients, if they didn't have hospice, they'd have to wait in the emergency room, or they would go without care, or they would be afraid to get out because of their weakened state, and they may die sooner or have a lot worse experience. So I think that's a thing that's not commonly known about hospice unless you've gone through that. And that's what I think is so important for people to understand, is that it's not something to be feared, but really embraced. And like we said earlier, that people, when they do experience hospice, they actually wish that they had done it sooner. So I think it's very important to make people aware of not only just that there is hospice, but also the benefits of it, and that people live longer and have so many benefits, not just for the patient that's ill, but also for the family. So there's so many other benefits that way. So I think the barriers, trying to break down the barriers for people either learning about hospice or experiencing it is very important. And I think the awareness, when I think of awareness and I think of November and the Hospice Month, that's the kind of things I think are the most important. Is just really allowing access and people to know that this is something out there and something that's really beneficial.
It sounds like I'm hearing a lot of benefits for having the family be supportive and really being able to have that service come into their home and still have their loved one being in their home and being comfortable in whatever home looks like to them, right? And so if that's being in their home, being in a senior living community, wherever their home feels the best to them, and that works best for their family unit and their family situation, and still being able to have the services that come in that are the most beneficial to them. And if that's pastoral services coming in, emotional support, being able to be available, having to be able to still take care of maybe young ones at home and working full time, and still being able to have caregivers come in and be able to care for their loved one.
Right. There's so many things. And so it's also one where if people, there's not really a too early a time to start either planning for the end of life or also planning for the future, just like so many things that we have. If you are at all questioning hospice or want to know more, any hospice would feel great about coming in and talking to you about what they offer and the times to think about it, so that you can get the earliest most benefit, and you can get those benefits as soon as you will need them. And I think that's just, everybody should kind of put that on their list, and to know, have that list of when do I think about hospice, when are good times to start that process, and talking with the physicians as well about prognosis, about time frames. That can give you an idea. And just in general, it's about 6 months is what the requirements are. If a patient's, and nobody knows our expiration date, so to speak, we don't have that stamped on our foot. But if the reasonable estimate is about 6 months of life left, then that's when we can start to think about qualifying for hospice. But there are plenty of patients that have been on longer than that because it's just an estimate, right? We make our best guess of what's going to happen. And then sometimes with the care of hospice, patients end up living what they call extended prognosis, or they live longer than we would have thought that they would. And that's great. And that's a good thing because they're getting supportive care, they're not in chronic pain, they're relieved, and they also have the support around them to keep them doing that. And there's nothing wrong with that. We've even had a lot of patients that get on hospice that they get so much pain relief and they get so much supportive care, they're actually able to come off of hospice. They no longer have that poor prognosis. They're no longer declining. And it's not for even several years after that they come back on because of the disease process itself.
That's amazing.
So, and that's a great thing. So that's why I think it's such a good service, because once you're on it, we're happy that you come off of it. you know,
Right.
because that means you're doing better. And so that's something to celebrate. And that's something, it's not a one-way ticket. It's
Right.
not like, oh, when we go on hospice, we're done.
Right.
Many times it's not. It's actually a new beginning because they actually get the care that they need.
Great.
People may have that question, like what's the difference between hospice and palliative care? If you want to, we can pose that.
Okay.
Palliative care is what is care when the treatment is no longer thought to be curative,
Right.
but sustaining.
Right.
And then when you get to hospice, it's that 6-month diagnosis from that. So care between hospice and what I guess would be termed curative care, which is the majority of our life, would be called palliative care.
Right.
And I think the more practical is not necessarily getting into the weeds of what is palliative care, but saying when we get to a point when we're supporting the patient, we're still keeping you going as long as possible, and we don't have anything saying, hey, there's an end in sight.
Right.
That's still palliative care.
Right.
And when we get to the point when our treatments are no longer working and we see a decline,
Right.
despite our best efforts, that's when hospice comes in and we have that 6-month
Right.
window.
Okay.
So that's kind of the way I break it out in my mind.
That's helpful.
When patients are in crisis, and they may not be able to answer for themselves, and patients are suffering, rather than embrace that as the end and talking about how to keep that comfortable, the knee-jerk response, what we've done all of our lives, is to, oh, we need to be in the hospital.
Right.
And we don't think about, is that going to make them better?
Right.
We don't think about, is that going to cause them more suffering?
Right.
We just think, this is uncomfortable, this is scary,
Right.
and we need somebody else to deal with this.
Right.
And that's a difficult situation to be in.
Right.
And what hospice can do is to help the families understand that patients will go through these changes. But they're going to go through those changes whether they're in the hospital or whether they're at home.
Right.
And the job of hospice is to make those changes the most comfortable and the least scary that they can be.
Right.
And when families think of it as it's their job to help this patient as almost in a paternalistic way or in a caregiver to a dependent way, then that becomes an option.
Right.
But when that question is framed in the way that I think we would all want our own situation to be framed, and that is, what would the patient want to have happen if they were watching this,
Right.
standing beside us, looking on with us, and they could see it and they could be part of the conversation about themselves? What would they say and what would they want to have happen? When we look at it that way, it becomes much easier to do the things that they would want done. Because then it's not about us having the responsibility to take care of someone.
Right.
And then as a caregiver or as a family, our responsibility is to do the things that they would want done.
Right.
And that they have expressed what they want, or even if they haven't expressed it, what we know about them and what they would want done.
Right.
And even if we don't know that, we also know too, and most people know, that if it was them in that situation, they wouldn't want a lot of those other things to happen.
Right.
So that's what we try to help patients understand and families understand about dealing with the patients. And when we can communicate that, then I think we have such a better bond with the patient, because we are lifting up their autonomy,
Right.
we are lifting up them as an individual, and we're respecting their choices.
Right.
And when we do that, not only does it help us with the patient, it helps the family with the patient, but it also gives them a level of respect and communication that is mutual in that situation. And that's one of the healings and one of the things that can be so gratifying and so rewarding at the end of life is when we don't fear those things, but we embrace the end of life as just a part of life itself and what makes life so precious. And then it doesn't have to be on the trip to the emergency room or during CPR that the loved one goes away, but it can be with loved ones surrounded with love and being kept comfortable with hospice. And when that happens, I think that's the point of what hospice can do. And that's the real victory of what we can have as a family and as a healthcare. That's when we really get down to it at our best. That's what I think hospice can be. And that's our job as hospice, is to really help families get to that point and to have patients have that kind of experience at the end of their lives. And so it's not easy, but it's a great challenge, and it's so worthwhile when we can successfully have those kind of conversations and bring patients and families into that knowledge and into that experience.
Perfect. Yeah, and just the importance of having just all that open communication, dialogue, really making sure everyone's on the same page, and to be able to have that bedside nurse, physician, all the different family dynamics that are involved in the care, including, and I can even say directly from like our experience, is the team members here, and so making sure that they understand, what is the expectation if we are having a concern or feeling like we're having a medical emergency. What does a medical emergency look like? If we're feeling like we are having a setback, what are our steps that we're going to take?
And it's so different too. Like if someone is on for maybe they are dealing with lung cancer or they have breast cancer or something, that they have a terminal diagnosis and they fall and break a hip. That doesn't mean they don't get to go to the emergency.
Exactly right.
It doesn't mean they don't get
exactly right.
I'm not signing away any kind of rights to do that. And we do need to get that immobilized. We may or may not do surgery. But we definitely want to get comfort care in that situation and the best we can. And so many times that's necessary. So we don't shy away from those kind of things. And what I like to tell patients and families when they ask about specific treatments, I tell them that there's no treatment that's off the table. There's no intervention or anything that the medical community offers that is off the table with hospice. However, we are only going to entertain the types of treatments and therapies that will cause the patient to be more comfortable. So if a transfusion is going to accomplish that, then we're going to have a transfusion. If surgery somehow would do that in the long run, then we entertain that as well, and we consider those things. But the point is that the goals become comfort and supportive rather than curative at any cost. So, or prolonging life at any cost. And if that cost is going to be more suffering, then we don't make that choice. So that's how we kind of evaluate treatments, but nothing on its face is off limits. And I think people get feel more comfortable with that, not feeling like that they're, that there's going to be something that they're going to miss out on, or that the patient can't have. And then also, if there is something with the patient's getting better, or there is an option for a patient that's better for them, then they can come off of hospice and pursue that and then come back. So there's lots of that give and take. So it really is just like any therapeutic relationship with a doctor and with a team. There has to be trust, and then a give and take. And so we see that all the time. So we leave in good terms. We want to have a good relationship, and we want the best for the family. And if for the family is better to come off of hospice, pursue some other things for the sake of the family's health and the patient's health and even mental well-being, knowing that they've done everything they can do, then they're free to pursue that. And we say that's fine. And it may not be what we recommend, but it also is something that if that's what they want to do, that's what they can do. And then if they want to come back later, if it doesn't work, or when they decline again, then we're happy to take them back. So there's not any kind of bad blood or any kind of feeling like you have to go down one prescribed pathway. We're advisors, just like your regular doctor. You can follow our advice or you can't, but it doesn't mean that we aren't here for you.
Right.
If you choose not to follow the advice, then that's up to you. And all we can do is just help you try to understand why, and do our job to try to say what might be our recommendations and why it's our recommendations. But everybody's individual and makes decisions for different reasons and has different priorities, and we won't always know the family's priorities, and we won't always know what their needs are at a given time.
Right.
We can only give our perspective on it and our advice.
Right.
We're advisors.
Right.
So, and then we have that good relationship, even if they don't, if they're not able to stay on hospice or they want to come off for whatever reason, then come back on. So we want to give them that autonomy and freedom.
Right. And those priorities with the patient or the family could change and adjust.
So much, and we're all changing. So we all want to just make sure that there's a safe place and a feeling that there's a welcoming and a therapeutic relationship, so that when they need us or they need that expertise or our expertise, then we're able to offer it again, and it comes and goes. So we want most of all for that relationship to be one that of mutual trust and respect, and then again there's that's good regardless of what happens. So we're here regardless of whether or not they're a part of it or not. We do offer that choice.
Great. And so that kind of leads me into another question, just talking about pain management. So I know when we talk about hospice, one of the things that comes up as a common question is how pain management is discussed and managed when you are on service with hospice. Can you talk a little bit about that?
Well, yes, pain management is a very important part of hospice. Many times that's why patients will seek hospice, because their condition is painful and they may or may not have had success with their primary care doctors or specialists, because many are becoming less enthusiastic about giving pain medicine, especially narcotics, because there is such an effort being made to stop the overdoses and use and abuse of medication, of these medicines. They are oftentimes abused, and that's a big problem. Not necessarily in the hospice community, but certainly as a society as a whole. So it's becoming increasingly difficult for patients to find that specific kind of pain relief. But what we've, as hospice doctors, palliative care physicians, and even primary care, one of the things that we do in hospice and in the rest of our practice is to develop lots of different avenues of pain relief, not just narcotics. And I think if there's a silver lining to the pushback or the crackdown, or however you want to say it, for the narcotic use in medical practice, the benefit has been is that alternative forms of treatment are becoming more available. Whether it's topical, there's alternative medicines, there is other therapies, music therapy, other types of virtual reality is even being used. Behavioral therapy. So many things that are not narcotic are being used as adjunctive therapy, in addition to being very good with pain management as well, in the traditional sense of narcotic use or similar medicines. So I would say that is one of one of the reasons to get involved in hospice is because of the pain management and the success that we have, because we have so much of what we do is pain management, but it's not just narcotics, and we are able to use so many different therapeutic modalities to get the patient comfortable.
That's great.
Yeah, so that's one of the things we enjoy doing.
That's great to hear, especially as families are having different conversations about what they're comfortable with and what the patient's comfortable with. So it's nice to be able to hear those different options.
Definitely.
And then when you are meeting with your patients and your families, are there certain cues or indicators that you look for that might be leading you to have conversations about your patients having different opportunities to live in a senior living community as a safer or better option for them versus living independently at home?
Yes, that's something that we're always in the back of our minds as we have patients and therapeutic relationships with older patients. We always try to assess the safety level of their homes. One of the things that we can do with one of the advantages actually of telemedicine is being able to actually see the home. When you are in a video type of a setting, it's easy for the patients to either show the home or walk around with the home, or a caregiver or a family member. We can see where there are potential risks. A home safety assessment can be done. We can also do that through our partners with Home Health. They oftentimes provide that when they're in the homes. And that's something that we can see. We also are sensitive to falls.
Sure.
Anytime patients have a history of falls, that can clue us in that we might be getting close to needing some support. Help. We start many times with home health and other kinds of rehab. And then we also obviously medically want to get to the bottom of what's happening to them medically, and that may be why they're falling. So there's a lot of reasons to assess that, but that can be a clue that we might need some more help. They may be in danger of being by themselves and need support services. So those are some things that we listen for and look for. And then we also just look for cognitive a screening that we do, the annual wellness visit that we oftentimes will do with our patients. And Medicare, really, they're paying for that. They want the patients to have that, and it's for a comprehensive assessment of a lot of different areas: depression, anxiety, risk of lots of different risk factors, both physically and emotionally and mentally. So as we go through that, it does give us some clues that we try to say, but basically we want to try to assess how well a patient can live independently, or at least outside of a facility. And that's different for different people. We find some families with a lot of resources can have either families themselves or caregivers come in. They can provide an environment that is every bit as caring and as advanced as even an ICU setting. And so there's no need for those patients many times even to go to the hospital. We have other times when patients may not have the basic things, and even just getting food and being able to do what they call the activities of daily living. Getting dressed, getting hygiene, cooking, cleaning, those kind of things are difficult because of limitations physically or emotionally or spiritually. Not spiritually, but psychologically. And so if there's limitations there, then they may need some support. They may need a facility that can be that for them and help them in that way. So we do try to assess that on an individual basis, and those are the kind of things that we look for. And we want patients in general to stay as independent for as long as they can. And so with all the support services and with our medical therapies, we want to make them more functional. So if we can use home health and aids and support in that way. We can use that and keep them independent as long as they can. And then when they are no longer able to function in that independent environment, then they can do a little bit of a step up with more assistance.
Great. Well, thank you so much for joining us today and having this wonderful conversation. This has been extremely helpful and great for the community. So we appreciate you joining us today, and thank you all for joining us. At the end of the video, we will have the opportunity for you to like, follow, and add any comments or questions that you have. And so he will be able to answer all of your questions for you. If you have anything specific, feel free to reach out. And thank you again for joining us.
Thank you. It was a real pleasure.
Thank you.